Okay, shall we start the lecture? Talk to me.
Yes, sir.
Okay, do you have any questions of yesterday? Do you have any questions from yesterday? Your silence says no, so I can understand. So my question is, do you have answer to my question, which I had asked you yesterday? Okay, that also answer is no only. So all right, let's continue today. So yesterday we had stopped at this slide where we were talking about the three layers of the blood vessels as well as three layers of the heart. That is the endocardium, epicardium, and the pericardium and the myocardium. Okay. Once you learn Greek and you come to know the meaning of these words, endo, myo, and peri, then you can just use these words everywhere else. For example, the same words remain for uterus, and the Greek word for uterus is metra. So it becomes endometrium, myometrium, perimetrium. Words will take, but then it is becoming of the uterus. Somebody is unmuted. Sangeeta Dubey, mute yourself.
मैं म्यूट कर रहा हूँ सबको, ठीक है? मैं आपको होल्ड में आता ताकि आप ही अनम्यूट कर सकोगे।
Okay. हाँ कर दे।
कर दिया मैंने सर, आप अनम्यूट कर लीजिए।
Okay, so like I was saying, we change the word metra, then the same things will become applicable for the uterus, right? So we know that there is something called endometrium in the uterus, myometrium. These words we have used so often. Similar, same words are there even for the heart. The word changes cardia and metra. But sometimes the organs or names, there are two names for things. For example, uterus, there is, when uterus is taken out, we don't use the word meterectomy, we use the word hysterectomy. So hystera is another word again for uterus. One has a Greek origin, one has a Latin origin. You don't have to break your head which is Greek, which is Latin and all. You have to just remember sometimes that there are two. Okay, like for example, stomach has two things. Stomach has a word called gaster, which means stomach, which you know very well, gastritis, gastric juice, etc., etc. Another word for stomach is venter. Venter. That's why the surface on which the stomach is situated, that is known as the ventral surface. So all animals, except stupid human beings, all animals are on four legs. Right? And because they are on four legs, this is the surface where the stomach is, and this is known as the ventral surface. Okay. The word dorsum literally in Greek means on which sun's rays fall. Dorsum, not so many words, but I'm just making you understand. Dorsum means sun's rays fall. So the surface on which the sun's rays fall is known as the dorsal surface. So anything that is falling from the sky, whether it is sun, rain, snow, everything that falls on the dorsal surface. Human beings are the only animals who started walking on two legs and saved money of two shoes and two socks and two chappals and landed up paying the doctor for their cervical and lumbar spondylosis, spondylitis, etc. Animals don't get any time backache. They don't have any vertebral cord problem, spinal vertebral column problems, because we'll see this in musculoskeletal system why this happens. Only human beings develop this. So dorsum is that surface on which the sun's rays fall. That's why if you see the dorsal surface of most of the animals, there is fur there is thick coating, scaling, coloring, everything is there, pigmentation, whereas the ventral surface is white, smooth, shiny. Classical example is the crocodile, alligator, right? This is all scaly, rough and all that, and this is all nice, smooth, ventral. In human beings, what happens is, because we are erected position on two legs, this is our dorsum and this is our ventral. But it is not truly correct. We have become erect in position. From bipeds, from quadruped, we have become biped, and that's why this thing's there. But remember that whatever is posterior is dorsal and whatever is anterior is ventral. But this is wrong, and this is only as far as human beings are concerned. Otherwise, this is the surface. So coming back to the thing is that you have to learn Greek words. They are important and they'll help you a lot. This is blood flowing through the heart. You've done this already in school, college many times. So I'm not showing you anything of this. Only remember, right side is deoxygenated blood and left side is oxygenated blood. And the blood of the left and the right side does not mix anytime. That also you have to remember. Also, when you see diagrams, let me teach you something. Below every diagram, the book, it is written there, figure number this and this, figure number so and so, right? Shows this, it's written there. We never read this. You know very well, you never read, I know very well, I never used to read. And then we think that this is all written by the author just like that. And this is not meant for me to read because I am very clever. I'm cleverer than the author and I don't have to read this. Stop that habit because this is wrong. This is absolutely wrong habit that you're doing of not reading this. Do you think every author of every book in every subject is stupid enough to write so much for you? There has to be a meaning. Unless you read what is written, either as a title of that thing, like the title of the slide, or what is written below showing what is this figure is showing, you will never understand. Or your understanding will be wrong, one of the two. For example, in this diagram, we are seeing the flow of the blood through the heart, but after we have taken a section of the heart. It's not written that this is a section of the heart. See this slide. This is showing you how the yellow color atria are contracting. At that time, the red color ventricles together are remaining as relaxing. And the two ventricles, when they're contracting, the atrium are relaxing. Also, you have to learn to read diagrams. Here you have to see that both atria are contracting together, both ventricles are contracting together. This is called reading the diagram. Reading the diagram, you'll understand only if you look at the diagram for some time. After you have read what is written here. If you don't read what is written there and just use your brains, you might be wrong. Okay. So let's take, for example, all of us know that this diagram is telling you that there are two kidneys. Okay. I've drawn them very close by mistake. So this is the right kidney, that's the left kidney. So whatever is written below that in that diagram, this you are not read, still you might be making a mistake. But let's assume that you are good and clever and intelligent and you have done this. Now the next diagram is showing this. Okay, this kidney. So now we are going to definitely assume this is the left kidney because we saw in the upper diagram, this is the left kidney. So naturally, this is left kidney. Is this left kidney or is this right kidney seen from behind? Is this right kidney posterior view? Has this kidney been turned like that and we are seeing the right kidney from behind? Unless you read what is written here, you will not know. So make it a point from today to read whatever is written there by every author because all authors are not fools. If you can read their textbook, giving them so much concession that they are cleverer than you, then please read what is written there also. That's the same author that you are reading. Okay? Don't think we are more clever than the author. So these type of diagrams will land you in trouble. It could be left kidney anterior view or right kidney posterior view. So please read this. Plus also make it a habit to read, see the diagram properly, nicely. Spend some time with the diagram and see it. Why I'm telling you that is, if you notice this diagram nicely, then you will see that the interventricular septum is a big muscular thing. And like I told you, in the top part or where the atrioventricular junction is, it becomes thin and membranous. See this much part, where it is in the skeleton. In the skeleton, there can't be muscles. So this is what you have to learn to appreciate from the diagram. This is the thin membranous part of the interventricular septum. And this is needed. It has to be thin. It has to be such that it can be pierced by something. And that's why the bundle of his and its two big branches pierce this membranous part. They cannot pierce the big muscular part. Okay, so learn to see diagrams like this. See diagrams like this, appreciate them. Animated diagrams are very useful. With that much, we are skipping little from the heart and we are going somewhat into circulation, and we'll come back to heart immediately. So since we were doing circulation in the heart, now what happens to circulation beyond heart? So all the deoxygenated blood is coming back to the right atrium. When I say all the deoxygenated blood is coming back to the right atrium, upper is coming from SVC, lower is coming from IVC, and then it goes into the right ventricle, because if blood has to be thrown out of the heart, it has to go to a ventricle which is thick-walled to generate enough contraction, to generate enough force into the blood for the blood to move. Remember that the contraction of the ventricle, the force of contraction of ventricle is being transferred onto the blood inside the ventricle. And it is the blood now which is under pressure. It's the same word that we use, blood pressure. Pressure of the blood, instead of that, it is blood pressure. It is this blood due to pressure that it is moving. It is not moving due to anything, but the pressure is gained, or the pressure is started because of contraction. So muscle contraction is causing the motion of the blood to go. So the blood goes into the lungs. In the lungs, it gets oxygenated, comes back to the left atrium via 4 pulmonary veins, and then it comes into the ventricle, left ventricle, and goes out via the aorta. Any vessel which is coming towards the heart, irrespective of the type of blood it carries, it is called a vein. So pulmonary veins which are bringing blood to the heart are called pulmonary veins, though they carry oxygenated blood. Okay, and any vessel leaves the heart is called an artery. So you'll say it's all right, sir. All veins carry deoxygenated blood except pulmonary vein. Make one exception. No, that is not the case. The rule is whether the blood is flowing towards the heart or away from the heart, because when we talk of maternal and fetal circulation together, then it becomes a problem. Okay, if it is mother's heart, then any vessel coming to it is a vein. If it is a fetal heart, any vessel coming towards a fetal heart, whether it's carrying oxygenated blood or deoxygenated, it's a vein. So that's why we stick to the one nomenclature. Vessel coming towards heart is a vein. Okay, so blood from upper half of the body. When I say upper half of the body, I'm using heart as a landmark. From the part of the body above the heart is brought by SVC, and part of the heart below, part of the body below the heart is brought by IVC, and it goes like this. Okay, so there are two circulations therefore established. One is known as the systemic circulation, where the blood goes to the organ, cells, tissues. It gives, blood gives out oxygen and takes in carbon dioxide. This is called systemic circulation everywhere in the body, except in the lung. In the lung, exactly the opposite happens. The CO2 is given out from the blood vessel. O2 is taken by the blood vessel and brought to the heart. So in the circulation, the exchange is exactly opposite. So there are two circulations that we have to understand. One is pulmonary circulation and another is systemic circulation. In pulmonary circulation, the thing is exactly opposite of systemic circulation. These are some words which you have to get acquainted with, get used to, because these are important words. Have you ever wondered why we use the word circulation? Why we use the word circulation? That is because the blood starting from the heart, right, goes through the whole body, completes a circle and comes back to the body. Anything, even if pulmonary circulation you take, it goes like this, comes back to the heart. So it completes a circle. Because it completes a circle, the word is circulation. So that is how words are derived, and you can understand that. This is again showing you an animated picture of how blood fills up in the two atrium. After it has filled up in the atrium will contract. So you have to concentrate on one part. First, you concentrate on the atrium. See, when the atrium is filled up, only then it will contract. And once the atrium contracts, then only the blood starts coming into the ventricle. And only when the ventricle is full, the ventricle will contract. Okay, this is very important, because next thing that we are going to do is based on this only. Now, this circulation of blood, which is occurring in the body, is dependent upon three things. One is the pump, which is contracting and sending the blood into circulation. Another is the blood itself. The blood itself. Okay, the fluid and the solid part of the blood itself. That is the content inside the blood vessel. And third are the blood vessels themselves, the container. So this is the container, this is the pump, and this is the content, right? Like in our own houses, water comes in the wash basin for us to wash our face. This water comes because the water has come from the municipality. It has stored in the building, and it is traveling through pipe and coming to our house. And there is a pump which is storing and sending the water. So these three factors are absolutely necessary for circulation to occur. And whenever there is no circulation, then the state of the body or the condition that we call is called shock. Whenever the circulation is not proper, we call it shock. We'll do this again, going back to this diagram. We'll come back to this diagram in 1 second, and we'll do that. So for shock not to occur, that is for circulation to remain proper, right? And we'll use this new word, that these cells, each and every cell, any cell in the body, it doesn't matter where it is located, each cell for its survival needs two things. One is oxygen and another is food. And all the time I'm not going to say food, so I'm making one word, glucose, right? So glucose and oxygen are two absolute essential things that the cells require to survive. If the cells get the oxygen and the glucose in the correct proportion, enough for it to survive, right? Enough for it to survive, not to die, then we say that the cells are getting adequate or enough, and that is called perfusion of the cell. The word used is perfusion of cell. Now, oxygen and the glucose or food or whatever is there is sent to the cells or is received by the cells through the blood vessels. So we say if the perfusion of the cells is good, that means blood supply to that part is good. If it is good, that means it is getting oxygen and glucose in proper quantity. And again, we'll go back to this definition and see in 2 minutes. So for that to occur, these three have to work properly. If one of these three is not there, then circulation is not there and patient is to shock. Okay. But since we did here two words, oxygen and glucose, here there is nowhere in this picture oxygen is coming. See, all these three things are properly functioning. But if there is no oxygenation, that means if the lung is having COVID in it and the lung is not working properly, the blood is not oxygenated enough for the tissues for them to do perfusion. Everything else is nice. Circulation is perfectly all right, but oxygen content is not there. So one more thing is needed for normal perfusion that we are adding now, that the vascular system, that means the blood vessels have to be normal, fluid blood volume has to be normal, the pump, that is heart, has to be normal, and there has to be normal air exchange. So if these four systems are working properly, that means perfusion of the cells is occurring properly and there is no question of shock occurring. But any one of these four is gone, the person will result into shock. Let's see just 2 or 3 examples for your understanding what exactly we mean by this. Same diagram. For example, if there is how the fluid volume affects. So when is fluid volume affected? In bleeding, burns, dehydration. Pump is not working. In a medical condition, we call it MI. In trauma, we call this cardiac tamponade or we call this cardiac contusion. When this either there is a injury to the heart by an injury, by a trauma, or by a medical thing called MI, when the heart is not working properly. I'm just giving you one example, that's all. Air exchange, that means lung is affected. How is it affected? One, there is a medical condition called pulmonary, or exactly medical condition is not put here. Pulmonary embolism can be there. There can be something called COVID, pneumonia, many things are there. And a traumatic condition called tension, pneumothorax. Vascular system, when it will get affected, that means the vessels themselves are affected. Vessels themselves are affected. So in spine injury, whenever there's spinal cord injury, there is something called neurogenic shock. Or there are medical conditions like septic shock, anaphylactic shock, or due to drugs and alcohol. The causes being medical and traumatic. 2 causes are there, and they can cause normal perfusion to be hampered, resulting into shock. Okay. There is this is normal perfusion occurring of the cells, means oxygen and glucose is in the correct proportion, right? And here the main thing is these cells survive. Survive means they live and they work and they reproduce. This is the part of perfusion, meaning these cells survive, they live and they reproduce. If the amount of blood coming to it decreases, so much so that one function is lost. If the blood decreases, one function is lost. First working is lost and this cell tries to live. So the day we are fasting, we are doing upvas, we don't eat, we still live, we don't die on that day, but we don't have enough energy to do work, or we rather don't like to do some strenuous exercising work, hard work, etc. So that is what it is. So this is when the blood decreases. This is alive. It's not dead. Once the blood supply will again increase, this will start working and this will become normal. Right? In pathology, this is called ischemia, where the blood supply decreases. But it can be restored back. And therefore, these cells can start working again and they can live properly. In terms of CVS, ischemia of the myocardium means a disease called angina. Okay, angina pectoris. When this blood supply decreases very much, the blood supply decreases so much that first the work stops, then they cannot remain alive. The cells start dying because of loss of blood supply. Then in pathology, we call this infarction. Infarction or gangrene or necrosis, depending upon some other conditions also. So infarction, necrosis, everything has been, all the Greek words that we know are there. These are called death, death of the tissue. This is death of tissue, right? And once the death of tissue occurs, that is called infarction. So this is MI. If it happens in the heart, this is myocardial infarction. This is just giving you an example of correlating pathology with the disease with your understanding. It is after this stage when the working and the cell death occurs that the whole body, now we are talking about cell level. If we take out from all the cell level and talk about the body level, then this is shock. So I'm trying to teach you how you correlate something at the microscopic level with the macroscopic level of the body. Now, this is what you have to do. You are now mature enough, knowledgeable enough to do this. But I'm giving you an example to make you understand that how from normal we can move towards abnormal, and this is how your thinking should go. Little decrease in blood supply, ischemia, reversible, lots of decrease in blood supply, death of the cells, infarction, necrosis, etc. And this is at cell level. If we go to body level, it is called shock. Next stage, of course, is multi-organ failure and then death. Okay, so that was a little away from this. Coming back to our topic again today. So shock, if shock should not occur, all these conditions should be fulfilled, and this is called normal circulation, which will cause perfusion of the cells, and perfusion is what is most important. It is the cell level which is again important. So perfusion can get hampered or shock can result from so many conditions that I have told you just superficially. Okay, now we are moving towards blood vessels. So the blood vessels which carry blood away from the heart are called arteries. Smaller ones arterioles, smallest one capillary. Capillaries unite to form venules, venules unite to form veins. Okay, if you see the color of the capillaries is purple in between blue and red, and that is how it is. These are names of some arteries and veins. You know these nicely. Only those which are not in black color, you have to remember carefully. Don't ever mistaken these things. There is no vein like aorta vein, right? Most of the times, the arteries and the veins have same name, but wherever they don't have, and they are very important, you cannot afford to make mistake. So there is nothing like aortic vein. It is only aorta. The corresponding veins of aorta are SVC and IVC. And there is no SVA and IV arteries. That is what I'm trying to tell you. Don't make these type of stupid mistakes. The arteries which are going to be in the neck and the brain and all are called carotid arteries. Right? There's common carotid, internal carotid, external carotid, but they are called all carotid arteries. Whereas corresponding to these, there are jugular veins. So there is no jugular artery and there is no carotid vein. This much, if you remember, there are more than enough. Rest of the names, even if you mix up, it's perfectly all right. These names you don't ever mix up. Okay. And there is one vein. There is no corresponding artery to it. That is called portal vein. It is a different thing altogether. It is not meant for blood supply. It is meant more for function, not for oxygenation. Means this is not concerned with, portal vein is not concerned with perfusion. It is for functioning. We'll see it some other time. These are the three layers of arteries or veins. The outer layer, the middle layer, and the innermost layer known as tunica intima or the endothelium of the blood vessels. And repeating that as long as the endothelium or the intima remains intact, intravascular clotting will never occur. Okay, layers remain same. In the arteries and the veins, there is no difference. The thickness of the layers vary because the artery has to withstand more pressure in it. Its middle layer is thicker. Its middle layer is thicker in size. Comparatively, the veins middle layer is thinner. But whatever is there in all three is same. Don't learn anything. None of this is important for you. Only remember that in arteries, the middle layer, which is consisting of muscles and elastic fibers, is thicker. Out of that, also we require only the muscle part. So in this diagram, you can see the middle layer. There is muscle here, right? If you read the word, it is still smooth muscle, like I told you yesterday, and elastic fibers. Two words are there. Okay. Just for your knowledge, elastic fibers here are more, smooth muscle is less there. Here also in the veins also there is smooth muscle and there are elastic fibers. So as I told you, everything remains same in all. In one it is more and one it is less. Now what we are interested in, let's pick up that. So an arteriole, that is a, sorry, not that, it is here. This is the arteriole. Arteriole is a small artery And the middle layer of this arteriole, there are muscles. These muscles are going round it. These muscles are going, if I take a TS, these muscles are going around the artery. They are in the artery, in the muscular layer, middle layer, and these are round in transverse section. In longitudinal section, of course, you can see how they are going like this. And these muscles can constrict. These muscles, when they become small, they will constrict. And when they relax, they will dilate. Okay. So these muscles can relax, contract, and cause for the lumen of the, see, they are outside the endothelium. Please understand. So they can decrease the size of the lumen or increase the size of the lumen. When they decrease or increase the size of the lumen, we call it vasoconstriction or vasorelaxation. We never call it vasoexpansion. It is called vasodilatation. Vasodilatation is a word used in reference to vasoconstriction, and it is dilated more than constriction. Yesterday, first thing I told you, muscles can only relax and contract. They cannot become bigger. They cannot become bigger, and therefore there is, of course, they can become bigger in size. That is size I'm talking about. Lengthwise, they can't become bigger. And therefore, if the muscles contract, it can cause vasoconstriction or back to its normal size, which is called vasodilatation. This is its normal size. The blood vessel cannot become bigger than this, like this. Of course, it can become technically, theoretically, in relation, and that occurs only in this condition. Okay, so this is something different. I'm not confusing you with that right now. So for all practical purposes, just think that the blood vessel can go back to its original position or can become smaller, and that is called vasoconstriction and vasodilatation. First thing you have to remember, vasoconstriction and vasodilatation occurs only in arteries, never in veins. So the word vaso is little wrong. It should be arterioconstriction and arteriodilatation, because these muscles are there only around the arterioles. They are not there around the venules, right? These group of muscles, circular group of muscles which are there, which can make the size big or small, and therefore they are called sphincters. They are called sphincters. Like there is sphincter at the anal end, there is sphincter at the urethral end, and some sphincters are supposed to be there but not there. We'll talk about it if we get time. So this acts like a sphincter. And where is this sphincter? Where is this muscle present on the arteriole before it can become a capillary? Therefore, these are called precapillary sphincters. These are called precapillary sphincters. And if these precapillary sphincters will contract, then the amount of blood going to these cells or tissues is going to reduce. And if these don't contract, and when you use a wrong word, vasodilatation, then this will be proper. So here, if we see a section of an artery, you see that there are three layers. There are three layers: intima, the middle one, and the outer one. You don't even have to know the names. Forget about it. Here, around the intima, you will see that there are circular muscles called precapillary sphincters. And in the capillaries, there is only the endothelium. So as I told you, endothelium is necessary for intravascular clotting not to occur. When we come back to venule, again, there is the innermost endothelium of intima, thin muscular layer and outer layer. And here there is a thicker muscular layer and an outer layer. Okay. This precapillary sphincter is very important, and we'll deal with it now. This is the precapillary sphincter. This is the precapillary sphincter. Depending upon the precapillary sphincter, the amount of blood going to these cells and for its perfusion will vary. This is very much simple to understand. If there is vasoconstriction, less amount of blood. Vasodilatation, more amount of blood. These sphincters, that is the circular muscle fibers. These circular muscle fibers, these are under the control of sympathetic system. There is an autonomic nervous system called sympathetic and parasympathetic, out of which only the sympathetic will control these. there is no, please understand that there is no opposite parasympathetic effect on these sphincters. There is no opposite parasympathetic effect on these sphincters. These sphincters are only under the control of the sympathetic system, and sympathetic system neurotransmitter is called adrenaline. You learn about this in pharmac. We'll learn about this again when we go and do nervous system. We'll talk about this. What is a neurotransmitter? So at present, if you don't know what is a neurotransmitter, don't get frightened. It's all right. Or if you just want to know, it's like a drug. That's all you learn. And it can cause constriction of these. Okay. So because it is coming from the sympathetic nervous system, it will cause a constriction of this. If it is not happening, if adrenaline is not going and causing vasoconstriction, they'll remain in the normal tone. And that is called vasodilatation, though there is no dilatation. Okay. So because this is under the control of sympathetic nervous system and the neurotransmitter which is liberated from the sympathetic nervous system is called adrenaline. This was the only exception I told you here. That in neurogenic shock, when there is spinal injury, naturally adrenaline will not be secreted. And if adrenaline is not secreted, all the sphincters will relax. All the sphincters will relax, and then there can be something wrongly called vasodilatation. Okay. Now, why the blood is flowing through the artery like this and not stopping here, or why is it flowing in the vein? Right? This we have to know. It is not that blood is coming, so blood is going. There is nothing like that. There has to be a movement. There has to be a force. There has to be something to push it. You can collect water in a tube and tell the tube to take the water away. It is not going to take. So these are not tubes. There are some things in it which will actively make it work. And the lower half of the diagram, we will do little later. This is usually the normal picture. So the amount of blood which is coming, these sphincters are not doing any vasoconstriction. They are relaxed. Blood is flowing into the capillaries, flowing from the capillaries into the venule. And this is how it is occurring. This is normal perfusion at the level of capillaries. If I don't want the blood to flow in this direction, right? I don't want the blood to flow here and here because this is my GI tract, but I want more blood flow in my lower limbs because I'm running. So I want more blood in my lower limbs. So in my lower limbs, what will happen is all these will be relaxed. All these sphincters will relax. So if all the sphincters relax, blood is going from here into this, into this. All the cells in my lower extremities are getting enough and more blood, and they can keep functioning. That is, I can keep running. Now, when we say that there is more blood going to the lower limbs because the lower limbs are active. I want to run. Where is this more blood coming from? See, we have been using words so nicely without understanding anything. Where is this more blood coming from? When I'm running, I'm not drinking some 2 liters of blood so that the blood will increase. When we say increase, where is this blood coming from? So in my GI tract, I'm going to say we don't need any digestion right now. Cancel digestion. My life is important. I want to run. So all these precapillary sphincters are now gone into constriction. Because they are constricted, blood is not going to go into all these capillaries like we saw in this diagram. Right? Blood is only going to flow directly from one of the arterioles from the capillary into the venule. This amount of blood is necessary here for it to live, but not to work. This amount of blood is enough for it to live, but this amount of blood for digestion. So we are shunting the blood from the GI tract, that is from the abdomen, into the lower limbs. So that's how more blood is going to the lower limbs. Okay. So when we say more blood, it is these precapillary sphincters which will shut down, close down, will stop circulation in unnecessary parts of the body and send to the more necessary part. And this can occur anywhere in the body. But please remember, precapillary sphincter is there only in the arteriole, and it is only under sympathetic control, not under parasympathetic control, because it can only constrict. If it is not constricting, then it is as usual, and that is wrongly called vasodilatation. Okay. This is a capillary, the size of the capillary. I'm just showing you, this is an electron microscope photograph. This is to show you that there is a size of the capillary, and this is an RBC. An RBC is supposed to be 7 microns in size, 7 mu. Mu is micron. Something is coming wrong. So if this RBC looks so big, then you can imagine the capillary size is only so much. Okay. These are normal heart rates. Now we are seeing the functioning of the heart. Before we see this, let's see this, that if I put on the switch, any electrical switch which is connected, let's say, to a fan, then the current from, after I put it on the switch, the current from the switch travels to the fan. After the current has traveled to the fan, then the fan starts moving. So the movement of the fan is its mechanical function. That is mechanical function. Fan is moving is mechanical function. The fan is moving because electricity came to it. So that is the electrical function. So in absence of electrical function, mechanical function will not result. Very simple, either current is not coming, wire is damaged, or the fan is damaged, but there will be no mechanical activity. Similarly, same thing happens in the heart. There is electrical activity, electrical stimulation first. Once the electrical stimulation occurs, next will come to the mechanical function. So electrical is first, followed as mechanical. Just skipping some slides. This is electrical conduction system, which we are going to do now in little detail, and then it will be done in great details in physiology. And after that, because of that, it is resulting into mechanical activity. So these two are mechanical activity. For them to occur, there has to be electrical activity. Okay. Another example I can give you is there's a well. This well, I want to put water in this field here. So we put a motor here, we attach a motor, and this motor will take out water from the well and will put it in the field. So the water coming in the field is the mechanical function. This is happening because there is electrical function of the motor. Now the motor will start working only if I put on the switch. The fan will start working only if I put on the switch. Correct? So there is a need of a switch. This switch in our body is on permanently on basis. Permanently on basis. Right from before our birth till the moment we die, it is always on. It is never off. And this switch which is on permanently is called SA node or the sinoatrial node. It's called the sinoatrial or the SA node, and it is situated in the right atrium, somewhere near the opening of the superior vena cava. Somewhere near the opening of the superior vena cava. Right? This transmits an electrical impulse. This sends out an electrical impulse. Okay. And the impulse then travels through the whole of both the atrium. And when we use it in plural, the correct word is atria. So it travels through both the atria and comes and collects in another switch known as SA node. Okay. So, sorry. It comes and collects another switch called AV node. So it is going from SA node, it is going through both the atria and it is coming to the AV node and it is stopping there. It is stopping. It is not going further. Full stop occurs. Okay. When this is still electrical current, please remember. Now, God in his infinite wisdom said, if I keep the heart nerve supply like any other organ's nerve supply, coming from the nervous system, whatever nervous system it is, central, peripheral, somatic, whatever, then if for any reason the brain is not working or the spinal cord is not working, because of the brain or the spinal cord not working, heart will stop working. So God said, no, forget it. Let heart have its own nerve supply. Own nerve supply which comes from the heart, which remains in the heart. It can be increased or decreased by the nervous system. Sympathetic system can increase the heart rate, and parasympathetic via the vagus nerve can decrease the heart rate, but it cannot start or stop the heart rate. Please understand this. The property to start an impulse in the heart, that is at SA node or at AV node or even at bundle of His, is an inherent property of the myocardium. Is an inherent property of the myocardium, which you learn in physiology, and that is called automaticity or autogenicity, meaning automatically it can generate an impulse, or automatically an impulse can keep coming. That is the meaning of the word, that the switch is on permanently. It will go on, go on, go on. Not only will it go on, but it will go on somewhere roughly, I'm just taking a round figure, 80 times per minute, every hour, every day, every week, every whole life. When this stops generating, then life will end. Till life is there, it is going to keep on and on and on. This is autogenicity or automaticity. It will keep on and on. Every fraction of a minute or a second, then impulse is starting. And depending upon how many times this impulse starts, that many times our heart will beat. And that is what is pulse. But there is a lot of difference between SA node impulse starting and pulse. Lots of things are there in between them. And we'll have to do this properly, and you have to understand this properly. That's why now the first part that we are doing, just learning, is the electrical conducting system, right? So where the stimulus impulse, which is same like a nerve impulse, and this is SA node, AV node, and whatever names that we are going to use, all these are modifications of myocardium. They are not nerves. These are not nerves. Please remember that there are not nerves. These are not nerves. These are parts of myocardium only. Myocardium is modified to form the conducting system. And that's why the myocardium cell is a different type of cell where there is no other cell like this in the body. That's why in the classification, we did myocardium as a separate cell or a separate muscle, right? These are not nerves. These are modified myocardium fibers. And this is forming the conducting system. So the impulse begins in the SA node. It spreads in both the atrium at the same time. It is not that it is going in right atrium first, left atrium second. It is going in both the atria together. Both the atria now are stimulated. Then the AV node holds it for some time, keeps it, does not transfer it. Then it transfers, gives it to the bundle of His. Bundle of His is passing to the membranous part of the interventricular septum, where it is not muscular. That is where the skeleton of the heart is. Then it divides into two branches from bundle of His. Bundle of His has got two branches. These two branches are also known as fasciculi, right? The right is one fasciculus, and on the left side ventricle being very thick wall, the left side immediately breaks up into two anterior and posterior fascicle, and it supplies the whole of the left and the right ventricles. But the stimulation or the spread of the impulse is together in both of them. See, both of them, the interventricular septum has got stimulated. From the interventricular septum, it is going towards the ventricle. Also remember, this is a cut section of the heart that we are seeing. Heart is full like this. We have cut it half and we are seeing like that. This is full, so it is going anteriorly, posteriorly, everywhere, three-dimensional. No diagram is there to show you three-dimensional. So you will have to see cut sections and understand. So the impulse has reached back to the atrioventricular junction to the skeleton of the heart, and therefore the impulse is not passed on to the atrium. Similarly here, once the impulse comes to the atrium, the impulse is not passed down directly into the ventricle. There is a blockage. There is a slow stoppage somewhere there, and that's why this, when we see this is an isoelectric line. Between the ending of the P and the beginning of the Q, on ECG, it is a flat line. Flat line means isoelectric line. Isoelectric line means there is no depolarization of any chamber, neither there is repolarization of any chamber, or there is no repolarization or depolarization of any cells. If there is no repolarization or depolarization, it will come as a flat line. And this flat line, which we call PR interval, not exactly, but PR, is because the AV node for a small fraction of a second does not allow the impulse to go into the ventricle. Now let's do a combination of both of them, the mechanical and the electrical. Impulse which has started from SA node has gone into both the atria. Both the atria, myocardium has got stimulated. So the myocardium will start to contract, will start. By the time it has gone through both the atria and it has come to the AV node, both the atria are contracting. Present tense. They are contracting. They are contracting. See that contraction now that will come. And this has to coincide with the atrium filling up. Only if the atrium is filling up, by that time, the impulse has gone through the whole atrium. The two are so well connected. The atrium fills up, the impulse has passed through the whole atrium. Now the atrium will contract. And now when the atrium will contract, blood is still going into the ventricle. If the impulse had gone down into the ventricle would have started contracting. Therefore, that is not happening. AV node is now blocking the impulse from going down into the ventricles. It has blocked it. It has kept it. It has not allowed it to go down. Because if it allows it to go down, atrium is just starting to contract. Blood is just going into the ventricles. Ventricles need time to fill up. And if the impulse goes down, the impulse will go into the whole of the ventricles, and ventricle will contract with maybe 1/4 or half the ventricle filled up. So the AV node keeps the impulse with it. It will leave it after some time. That sometime is when the ventricle's mechanical function is ending. Then it sends the impulse down and it sends it into BOH. The branches of the BOH and the smallest branches of the conducting system are known as Purkinje fibers. Right? These are smallest. These are called Purkinje fibers. And Purkinje fibers are the smallest ones, the last ones. And they are going from the endocardium towards the epicardium. That means from the inside to the outside. And it is going from the apex. Forget this part, because which base and which apex, this will not go. We can do this when we do ECG. So this is going, this also you forget, second, this endocardium fiber. The smallest one is the Purkinje fibers. So when the impulse then reaches the ventricle and the myocardium of the ventricles stimulated, ready to contract, by the time the blood has filled up into the ventricles. See this is blood filling. See that fraction of a second is needed for filling. While that filling is occurred, the impulse is also traveled through the whole of the ventricle. And once the impulse has traveled through the whole of the ventricle, now the ventricle will actively contract and throw the blood out. So electrical function precedes mechanical function. Electrical function in the atrium or in the ventricle is first, mechanical function is later on. And that the ventricle should not get stimulated first and start contracting with half its quantity. AV node will hold the impulse and keep. And that's why we get after PE, where are we? After PE, there is always an isoelectric line. This isoelectric line denotes that there is no passage of impulse anywhere into either the atrium or the ventricle, and this is where the AV node has taken it and kept it with it. So if the AV node holds it for longer than necessary time, then we say this is a heart block. And if there is a heart block, all impulses will not go naturally, so the heart will beat at lesser rate, and that is called bradycardia. That is DR, bradycardia. So that is called heart block or conduction block or AV block. There are so many words to say. See, everybody in cardiology wants to become an expert, so everybody uses the new words. So these are called AV blocks, heart blocks, bradycardia. The problem is with the AV node. The AV node is holding it for more than necessary time, and it is not allowing it to go. More of this you will do with ECG and with physiology, but what I wanted you to basically understand is an electrical impulse is coming followed by a mechanical. Going back, now what happens when there is mechanical function, and that too we are interested in the left ventricle. We're not interested in the right ventricle. Because right ventricle is sending it only to the, let's keep this diagram so we can write. Okay. So with whatever force the left ventricle contracts, that force is transmitted onto the blood inside. So we say the hydrostatic pressure of the blood is dependent upon the force of contraction of its walls, right? If the wall contracts more pressure is put on the blood. If it contracts less pressure is put on the blood. This is in disease condition. In normal condition, it contracts, and that force from the contractions force is converted into, or the pressure from that is converted onto the pressure inside the blood. And that is what we call blood pressure. Blood pressure is the pressure with which the left ventricle has contracted. And because the left ventricle has contracted, it has put that much pressure onto the blood, and that is blood pressure. Our definition of blood pressure is something different, and you will say that, no, sir, what you're telling is different. Our definition of blood pressure is the pressure exerted by the blood on the lateral wall of the artery. This is the blood pressure. Pressure exerted by the blood onto the lateral wall of the arteries. Agreed. Where did it come from? This question is the main question. Where did it come from? The blood inside, there is pressure in it and it is exerting on this. Agreed. But where did the pressure inside this blood come from? No liquid can just get pressure by itself. If it has to have contain some pressure, that pressure has to be the contraction of the left ventricle. The contraction of the left ventricle has forced the pressure onto the blood. Theoretically, this is approximately, we are just using a figure. I'm not saying this is the correct figure. I'm just saying something to talk. So this pressure is 120 millimeters of mercury, not of water. 120 millimeters of mercury pressure. What it is, if you want to know, cut an artery in the OT and you will see the blood going and hitting the roof of the OT. That is 120 millimeters of mercury. Okay. So with this much pressure, the ventricle which contracted has converted that ventricle's contraction pressure onto the blood and gave the blood that much pressure. And it is because of this pressure of 120, blood is going out into the aorta. And now aorta has got inside it muscular muscle. So if I show you like this is aorta, these are the muscles in its middle. These muscles will contract and push the blood more distally. So this is, where is it? This is left ventricle, all the blood has gone into this. So this aorta has bulged like this. Aorta has become almost same size as the ventricle because there is elastic fibers inside. Now those two words I had used, see how they are coming to work. There are elastic fibers, so it will allow the aorta to stretch. But aorta does not want to keep the blood here. It wants to send the blood more distally. So the muscles which are there in the aorta, right, the muscular fibers, they will contract. The muscles which are there in the aorta, they will contract. When they contract, blood will go here. So this part of the aorta will become like this. As we keep going further and further, this will keep becoming like this and like this. So if we eventually draw, it is something like this. Every time the ventricle will contract, one such thing will keep coming. So there is going to be expansion because of elastic fibers, and then those muscle fibers will contract and the blood will go more distally. And it will keep happening like this in every small artery. Every small artery, arteriole, it will keep happening. If this is, where am I drawing? If this is a change in color, if this is a bone, and if this is an artery, on top of the bone, which is now doing this. Correct? As I told you, this artery or arteriole will also do this because of the contraction of the left ventricle. Left ventricle is pushing the blood out at 120 millimeters of mercury. This 120 millimeters of mercury is pushing the blood here, from this aorta into the axillary artery, into the brachial artery, and into the radial artery. Same force is still going on. On the radius bone, this is the artery which is becoming big and small like this. If we put our fingers here, we can feel this pulsation 1 time, 2 times, 3 times. And if we go on counting for a minute, we'll be able to feel the pulsation for exactly that number of times in which the left ventricle contracted. Left ventricle contracted at that number of times as the SA node sent the impulse. So the impulse coming from the SA node, which is an electrical impulse, has got transferred to a mechanical activity of the left ventricle, and the alternate expansion and contraction of all the blood vessels all along till the radial artery is doing this. And if I keep my finger here, then that one wave is coming and hitting. And if I count those waves will be same as the rate at which SA node is sending out the impulse. And that we call as pulse. So pulse is felt at different places, as you know, carotid, radial, dorsalis, pedis, posterior tibial, popliteal, brachial. But pulse is not originating at any of these places. Pulse is originating in the left atrium. It is the contraction of the left atrium and the force with which the blood is coming out, which determines the systolic blood pressure, and it is the contraction of the left ventricle which determines the pulse. Suppose there is one big lake. In the middle of the lake, I put a big stone. Don't ask how I dropped a stone into the middle of the lake. That is not your concern, right? And then because of this stone, there are waves formed. If I put a stone in the lake, waves are formed like this. If I'm standing on the edge of the lake here, the waves will come and hit me. It doesn't mean the wave started here. The wave started because the stone was put in the middle of the lake. Somebody threw the stone in the middle of the lake. That's why the waves are formed. So the pulse that we feel, radial pulse, carotid pulse, this pulse is not because it started here. This pulse is because of the contraction of the left ventricle. It is the contraction of the left ventricle with that much force that is transferred onto the blood. That is the pressure of the blood, and that is the systolic blood pressure. Understood? So blood pressure and pulse are contractions of left ventricle. One is its physical and one is its transferred thing. So these two, pulse and contraction of the left ventricle, pulse and BP, are coming from the left ventricle. Please remember that. And this force is so much that it is transmitted everywhere into every arteriole. So at this end, see now, so many things we are taken for granted. We never knew also about this. At this end also, there is pressure, which is systolic blood pressure. Approximately, maybe a little less, but let's stick to one word. There is systolic blood pressure, right? Because of this systolic blood pressure, between the capillaries, the plasma will come out. When we say that blood comes out at the level of the capillaries, going to the cells, it is not really blood. It is only plasma coming out. It is only the fluid which is coming out. This fluid can come out not on its own. If it can come out on its own, it would have come out everywhere. It is coming out only because this fluid is squeezed out of the capillary by the pressure of the blood, that is by the contraction of the left ventricle. That pressure is transferred onto this arteriole here. And that is how it is coming out here. And of course, the precapillary sphincter is deciding how much to come out. But how it comes out is depending upon the pressure. There are two different things. Okay. We take it for granted that at the capillary level, blood comes out, blood goes to the cells, gives the cells nutrition and oxygen and comes back. It is not so simple. It is not very simple. It is really complicated. This is the cell. Do you know that the cell is containing fluid? You will say, no, cell is solid. I'm saying the cell is containing fluid because for years together, we have been telling that whatever is inside the cell is called intracellular fluid. We are saying there's fluid inside the cell and we say cell is solid. See how stupid we are. There's intracellular fluid inside the cell. There is extracellular fluid outside the cell. Just taking any color. There is extracellular fluid outside the cell. Extracellular fluid outside the cell. Therefore, if anything from the blood change colors, if anything from the blood has to go into this cell, that also has to be fluid. If it is solid, it can't go because everything is fluid. So, from the blood, only the plasma, which is the fluid part of the blood, plasma will ooze out or will come out between the capillaries, and that is called capillary permeability. Again, the capillary permeability is a different chapter by itself. How much to allow it to go out, etc., whether to allow cells to go out or not is something different, which we might do when we do lymphatic system. So because of this capillary permeability means allowing it to come out. Permeable means permitting it to come out, the plasma will come out. This plasma which is coming out, which is fluid, is rich in, now I'm taking the example of glucose, is rich in glucose. Compared to what? Compared to the glucose in the ECF. Therefore, this fluid being there, now a chemical process will start, right? Osmosis and this and that and etc., things that we have learned in chemistry. And the ECF is now becoming rich with glucose. Compared to that, the ICF is not having enough glucose. So from the ECF, glucose travels into the ICF. Again, by same chemical processes, and now we know a lot of molecular things and how it goes. There are channels and this and that, but I'm still making it easy that it is the concentration of the amount of the glucose from the plasma into the extracellular fluid, into the intracellular fluid, making you understand that everything has to be fluid. If there is something solid in between, then this process will not occur, right? This is going like this, oxygen is going, everything is going. Full stop here and rather keep this in brackets here and we'll come. What is plasma? Let's see what is plasma. This plasma is going out, so we should know what is plasma. So plasma by definition means fluid. By definition, it means fluid. You have learned this since school, right? There is a cell. Cell has a nucleus. Cell has a cell wall. and there is cytoplasm inside. The word cyto stands for cell, and the word plasma stands for its fluid. So cytoplasm from the word plasm means fluid. And now we know that blood contains two things. One is called cells and one is fluid, and that fluid part is called plasma. Of course, it is also called serum, but we are not going into that hair splitting things. What is the difference between serum and plasma? Today we are. So we are talking about plasma. So the plasma is the fluid part of the blood. This fluid part of the blood, plasma, contains every organic and inorganic substance that the cell needs. That means inside the plasma, there is glucose, there is amino acid, there is fatty acid, there are hormones, there are electrolytes, there are vitamins, there are coenzymes, there are enzymes, there is everything that a cell needs is in dissolved state in the plasma. Everything is dissolved in the plasma, right? Please don't think glucose is like small packets of Glucon-D traveling in the plasma. Everything is dissolved. When I said dissolved, what I'm trying to make you understand is, if you're making lime juice, we are taking water, salt, lime, squeezing lime, sugar, and we are mixing everything. After you mix everything and make it lime juice, you will say, give me lime out of the lime juice. It is not possible because it is dissolved. Similarly, every organic and inorganic constituent of blood is dissolved in the plasma. It is in a dissolved state. And when this plasma comes out, we took example of only the glucose. Just for understand, we said glucose, but everything that the cell needs is coming out from the plasma, is going into the ECF, and from the ECF, it is going to the ICF. This is all chemical processes, and this is physical process, and this is happening because of the pressure of the blood that the fluid is coming out, right? So the fluid has come out of the capillaries because of the contraction of the left ventricle. That is the pressure of the blood, systolic blood pressure. Now the amount of the fluid inside the ECF has increased, inside the ICF has increased. Once the volume increases inside the ICF, the pressure increases, and therefore the fluid again comes out into ECF. The volume of the ECF increases, therefore pressure of the ECF increases, therefore fluid now travels back. Therefore, the fluid which is coming into the capillaries is not because of something here, is because the pressure in the capillaries has increased, because the volume has increased, and therefore it comes back into the capillaries. The fluid re-entering the capillaries by osmotic attraction and by its increase in volume and therefore increase in pressure. What I want you to understand is this is not a simple process that we talk about. This needs explanation. It has to understand why it is occurring. And now it has come back into the capillary. Now what is the pressure in the capillary? Practically zero. Because there is no heart in the... So now the pressure is practically zero. Just for talking sake. And here the pressure was 120. Okay. So the pressure is all used up, and the pressure which is there now in the veins is almost zero. These veins therefore combine together. Smaller veins combine together to form bigger veins so that their volume increases. If their volume increases, their pressure increases. And then there is something called gravity, which helps the blood to go towards the heart. And if there is no gravity, then there are muscles which are contracting, the calf muscles, and therefore the calf muscles are also known as the second heart because they're pumping the blood towards the vein. And there are many other factors which help it. The vein has got valves so that once the blood comes like this, the blood cannot go back like this. There is a valve here inside the vein which blocks the backward flow of the blood. And when these valves are damaged in the veins, then there is something which is known as varicose veins. Why I'm telling you all this is I'm making you understand what is normal and what is abnormality. Right? So there is no pressure of the blood inside the veins. Pressure of the blood is inside the arteries only. And this pressure is utilized for perfusion. Because again and again, the whole story comes back to perfusion of cells. If there is perfusion of cells, everything is okay. If there is perfusion is hampered, everything is gone. And that is why we need only perfusion, perfusion, perfusion. So if perfusion of cells is proper, then we use a big word in physiology, that the body is having hemostasis. There is hemostasis of the body, or the body is proper. And when we do this in disease, we say that the body is now, when we have corrected the disease, we say that the body is hemodynamically stable. That means the person will remain alive. Then, of course, you have to do something to keep him alive. So this is not hemostasis, this is homeostasis. Sorry, I forgot. Homeostasis. This word you must have heard in physiology. So that is homeostasis. Okay. So we have seen so many factors are necessary for the survival of the cell. And for survival of the cell, heart is working, this is happening, that is happening, all things are happening, and that's how everything is surviving. This is a diagram of fetal circulation, right? Fetal and maternal circulation. Okay. Now, I don't know whether this is the mother or this is the whose heart this is. This is mother's heart or this is the fetus's heart. So let's see. So this is the placenta. So from the placenta, the blood is coming like this. This is the umbilical cord, and the blood is coming from the umbilicus, and red color blood, that is oxygenated blood, is going like this. This oxygenated blood which is going like this is the umbilical vein. This is the umbilical vein. Since below the, so this is fetus's heart. This is the umbilical vein which is getting oxygenated blood. I'm taking a shortcut, bringing it into the inferior vena cava. Forget this part. Okay. It is taking it into the inferior vena cava because umbilicus is below the heart. So it is going into the inferior vena cava. In the inferior vena cava, also deoxygenated blood from the lower half of the body is coming. So oxygenated and deoxygenated blood are mixing in the IVC. IVC is opening in right atrium. In right atrium, there is deoxygenated blood coming from SVC. There is deoxygenated blood coming from IVC. And there is nice oxygenated blood coming from the umbilical vein. But we call this umbilical vein because this vessel is bringing blood towards the heart. Whether it contains oxygenated blood or deoxygenated blood is not our part of the definition. If it is bringing blood towards the heart, it will be called a vein. It is coming from the umbilical opening, from the umbilical cord, from the placenta, and therefore we call this umbilical vein. So the blood which has come into the right atrium is a mixture of deoxygenated and oxygenated blood. So we'll use the word mixture. It is neither O2 blue in color, nor it is red in color, it is purple in color. Correct? This blood from the right atrium normally after birth should go to the left atrium. Sorry. From the right atrium normally will go to the right atrium. Sorry, I'm making a mistake. From the right atrium will go to the right ventricle after birth. From the right ventricle, it will go all the way to the lungs and then come back again to the left atrium and again to the left ventricle. See, before birth and after birth, the difference is only, just for talking sake, we are taking 1 minute. Before and after birth. So after birth, we cannot make all the blood vessels in 1 minute. So all the blood vessels are already there existing. The tricuspid valve is working. Blood is coming into the right ventricle. Okay. There is something called pulmonary trunk existing. Pulmonary arteries are existing. Pulmonary veins are existing. But the blood in all of them is not getting oxygenated. Though there is a pathway, though there is a place, though there are arteries and veins, there is no oxygenation because the fetus is not breathing. Fetus is not breathing. So the blood which will go to the lungs will also come back to the heart. Same way it will be mixed blood. There is no oxygenation of the blood. But what I'm trying to tell you is that the arteries, veins have to be there ready. You cannot say after birth in 1 minute, the blood vessels will be manufactured. All have to be there. All are there. It is like we have built the road, we have built the house, we have built the dam. Everything is there. Nobody has come. That is the only difference. Structure has to be there. The full structure is there. In 1 minute, we cannot develop structure. So everything is there, but there is no oxygenation occurring. But the blood does go to the lung, does come back from the lung. Please remember that. Though we are telling that it doesn't go, it goes. There has to be a road for it to go. Amount of blood going to the lungs from the right ventricle is very little. Say 5% of, just for like that. I don't know how much percentage goes. I'm just using a word. Say 5% of the blood goes from the right ventricle through the pulmonary trunk into the lungs and returns from the lungs. Okay, that is that. That is to make you understand that the pathway is there, everything is there. The whole system can start working the moment the child cries, and he takes oxygen for the first time inside. But what happens during fetal circulation? Let's see that for 1 minute only. Then we'll stop. So all the blood that has come to the right atrium goes to the right ventricle. Part of it has gone to the lungs. But most of the blood travels from ear to ear. Travels from ear to ear into the left ventricle. And from the left ventricle, it goes into the aorta and into the body. Whatever little went to the lung also came back to the left atrium. And from the left atrium, it came to the left ventricle. So everything came to the left ventricle, and from left ventricle, it has gone into the body again. So the body receives mixed blood. Every time it receives mixed blood, again oxygenated blood keeps coming. So this is just rough idea, just a rough idea. Since the cells will receive mixed blood, right? The cells will need optimum amount of oxygen for the blood supply. Suppose this is a cell-fetal cell. For this to survive, it will need blood supply 2 times because it's mixed blood. Na? So when 2 times blood supply will come to it, it will become oxygen will be proper here. Roughly, that's why fetal heart rate is double of the adult or the child's heart rate. This is just a rough way of for you to guess or understand that the fetal heart rate will be twice that of the child's heart rate. Okay, have you understood this much in fetal circulation? If you have understood, do you have any questions to ask in fetal circulation? I have unmuted you all. You all can unmute yourself and you can tell me, do you have any questions in fetal circulation? Do you have?
No, sir.
No. Okay. So I told you yesterday that I'll teach you something wrong, and I've taught you that wrong thing purposely to make you understand that this, I've told you blood is going to go from this right ventricle to left ventricle. I told you this just now. Now see this. See the size of the interventricular septum. Do you think if the blood goes from ear to ear through a hole in between the interventricular septum, and as soon as the child is born, in 1 minute, this hole can be filled up? Do you think normally all fetuses, when they become newborns, neonates, this hole can be filled up in 1 minute? No. So I taught you all wrong. I taught you all wrong to see whether you remembered that interventricular septum is the thickest wall of the heart. It is the thickest wall of the heart. We can't fill up this hole in 1 minute, and everybody is not born with PSD. VSD is a very, very rare condition, and that child may or may not survive also. Ventricular septal defect. Atrial septal defects are very common. I mean, more common than ventricular septal defects, and the child survives. Now, this is what I wanted you to understand, that you are going on listening to me talking, but you should also absorb it. When I tell you sometimes 3 times, 4 times that the interventricular wall is the thickest wall, there has to be some meaning. Why am I going on telling you this? And that if you don't realize, you miss the importance. So you should always remember things which are repeatedly told have got more significance. You have to again go home, check it, and find out. This person is still doing this. Somebody who had drawn yesterday is drawing today again. Okay? Don't do this because I can't rub it out. Now let's see really what happens. What happens is the blood which has come in the right atrium, from the right atrium goes into the left atrium, and from the left atrium into this. Whatever blood goes, little blood goes into the right ventricle, from the lungs also comes back to the left atrium and comes into the left ventricle, and from the left ventricle into the whole body. That means there is a hole existing between the right atrium and the left atrium. Atria walls are thin, so this gap can be closed faster, easier than a gap in the interventricular septum. But still, it is a wall, it is a muscular wall. You can't fill up a gap in 1 minute. Right? So let's exactly see what it is for just 1 second, because this is important to understand. You will be dealing with children also. So this part you have to understand. Now, what I'm going to do is, I'm going to draw an interatrial septum. This is the septum between the two atria. In the neonate, and the blood from the right ventricle does not go to the left ventricle. This is deoxygenated blood, and this is oxygenated blood. They two don't mix, like in us, in adults. Now, this interatrial septum which I have drawn, this line, I'm going to redraw. Okay? So, interatrial septum first starts growing. Say, forget the actual thing. I'm just drawing for our understanding. Is growing from the lower end, from the floor of the atrium. But it does not go till the roof of the atrium. It stops. And this is called first one. So, primum partition. First one, primary. Another one starts growing from the top, that is from the roof of the atria. Now there's only one atrium, right and left is not made into parts yet. It is one big huge atrium. It starts from the atrium and it comes downwards and it remains like this, and it is not going to the floor. Okay. So when the blood collects, so it is something like this. When the blood collects in the right atrium, it will push this. So this opening is created. Blood will go like this into the left atrium. Okay. So there is no real hole. Whenever we talk about hole, we always assume it is circular or oval in shape. We never think of a triangular hole, rectangular hole. Never we think of rectangular and triangular holes, especially not triangle, rectangular or squares, at least sometimes you will think of. See our windows, look at the windows in your own house. You will find that they're rectangular, that the hole is rectangular, which is closed by a window. But we never think, we think of only round. And so it is something like this. When, or I'll put like this so you can see, when the blood in the atrium will collect, it will push this like this, and the blood from this side, my side will go towards that side. Okay, from the right atrium, it will go towards the left atrium like this. When the left atrium will contract, this pressure will push this here and it will not come back into the right atrium. This is also important. So when the blood here in the left atrium will increase, right? Blood will fill up the left atrium. The pressure of the left atrium will push this wall against this. So septum primum and septum secundum will come to lie against each other. Now, after birth, what happens is the child cries for the first time, lungs are working, and the blood from the right atrium via the right ventricle has gone to the lungs. And the blood from the lungs has come back to the left atrium. So at that same fraction of a second, there is blood in the right atrium and in the left atrium. For the first time, there is blood equal in both right and left atrium. And because the blood is equal in both atrium, naturally the pressures are equal. And therefore, this septum does not move. This septum does not move. This pressure is pushing it against that. So this and this are like this. Because previously what was happening was, there was blood only in right atrium in fetal life. There was no blood in the left atrium. The blood went to the left atrium from the right atrium. It never came from the lungs. But now when the child starts breathing, blood is going and coming from the lung also, and the blood is coming from both the parts of the body, that is superior and inferior vena cava is also bringing blood, and it is coming from the lung also. So there's equal volume of blood in the left and the right atrium, and there's equal pressure, and therefore the septum primum and the septum secundum are opposed to each other like this. They are not now moving. They are fully like this, and in a matter of few days to weeks, fibrosis will occur and it will become one wall, and that is called interatrial septum. Okay. Sometimes what happens if this size is less? This is primum and this is secundum. If their size is less, what will happen even after birth? This will come like this and still allow blood to go like this and like that. And that is intraatrial septal defect, or ASD, atrial septal defect, because both are not of the same, both are not overruling each other. They were all almost of the same size, and therefore the hole will still exist. But don't think of round holes. This is just septum which are moving away. Okay. That is as far as circulation, fetal circulation goes. We have still got half an hour. We can at least complete this. Now we are learning coronary circulation, or at least the slides are of coronary circulation. So we'll learn that. First of all, we have to see where is the coronary sulcus. Right? Wherever there is coronary sulcus, there the coronary arteries will be. And then we have to see the branches of the arteries, the most important ones, so that when you see a coronary angiography, or if your boss is talking about coronary angiography, you should not stand like a dumb person there, not knowing what he's talking, and say, oh, coronary arteries and all, I don't know. It is very simple. By the time I finish showing you 10, 12 slides, you can also talk like a parrot as far as coronary circulation is concerned. It is very, very easy. Of course, I'm not going to minute details. We are only doing gross big ones. Okay. But before I go into coronary circulation and forget what I want to tell you, let me start that. Coronary circulation, so many slides are there, we can't forget. Okay. Now the whole of the body will receive blood. Whole body, whether it is pulmonary circulation or whether it is systemic circulation. The whole body will receive blood when the ventricles will contract. Whenever the ventricles will contract, naturally blood will go to the lungs and the whole body, and they will receive blood. So full stop. The contraction of the ventricles, we use the word systole. So we say during systole, it will happen. But when we say systole, are we talking about the systole of the atrium or the ventricles? So for all practical purposes, we do not consider atrium at all in cardiology. In cardiology, everything is concerned about is ventricle, ventricle, ventricle. That's what I told you yesterday also. Ventricle is the most important thing. Atrium is not important. So when I say systole of the heart, systole of heart, heart has got atrium and ventricle, but we are referring to only ventricles, and this means systole of ventricles. Systole of ventricle and systole of the heart, both are used synonymously. When the word systole is only used, or the word diastole is only used, and even the word is used of the heart, it means of the ventricle, because we are really bothered about ventricle. So the whole body gets the blood supply during systole. When I say systole, it means systole of the ventricles or systole of the heart. Here the word heart and ventricle is used synonymously, functional. Okay. Now, so I'm just giving you an example. Suppose this is the renal kidney and this is the renal artery and there's blood here. With the next contraction of the heart or the next contraction of the systole of the ventricles, the blood which was here will get pushed by more blood coming, and the blood is going into the kidney. This is pushing the blood which was before it, that is pushing the blood there, that is pushing the blood there, and that is pushing the blood into the capillaries. It is going into the capillaries, that is pushing the blood into venules. It is going on systemically because this is circulation. It is completing the circle. So this is what I mean when I say that the body gets the blood supply during systole of the ventricle or systole of the heart. That means the blood is moving. And of course, 80 times there is systole in 1 minute. So it is continuously moving all the time. Whole body gets it except the heart. Heart does not get blood supply during systole. Please remember that. Heart does not get blood supply. That means when we say it is getting blood supply, means it's getting nutrition. That means it is resting. The body is resting, it is not working. Whenever we want to eat food, we take a break. The lecture gets over, the work gets over, office, there is a break, and then we can eat food. So the heart can't eat food when it is working. Simple logic. God has made it like that. The heart is contracting actively. Both the ventricles are contracting. You tell it, eat food. It cannot eat food. It is working. So it will eat its food or it will get its blood supply only during diastole when it is resting. Only during diastole when it is resting. Okay. So what happens is that these are the semilunar valves. I'm not drawing, I'll point out so it will be easier. When the blood, remember ventricle is below this, underneath. Aorta is this. This is aorta which has been cut out. This much is ascending aorta that we are seeing. Okay. This is the ascending aorta which we are seeing. Ventricle is below, or in this slide, we'll say behind. It is behind. When the blood is coming from there, it is going to push this cusp against this. So this tip is now going to be here. First, we'll only see this tip will come here and this tip will come here. So this is going to come, this much part is going to be here. This part is going to be here. This one will be here. So the cusps have opened up from below, because below the ventricle there is pressure, and because of the pressure it is sending the blood up, and the cusps have opened like this. Cusps have, I can only show you two at a time. Both the cusps have opened like this. So let's take cusp where it is written C and where it is written this cusp and this cusp. It has opened and it has come in contact with the wall of the aorta. So if this is the wall of the aorta, of course, I'm taking a transverse section of the aorta, and these are the cusps. The cusp is touching the wall of the aorta like this, and the blood is going up into the aorta. Okay, it has pushed the cusps like this, like I showed you in this diagram. Okay, same way in the pulmonary also, no difference. It is going like that. Now what happens is when the blood has gone into the aorta, the pressure of the blood in the aorta is more compared to the ventricle. And the blood tries to rush back inside. Right? Here everything is just physics. These valves are acting only as an obstruction because of physics. The valves cannot act on their own. Right? So the blood is trying to come back into the ventricle because the pressure in the aorta is 120 and the pressure inside the ventricle is diastolic, which is round figure 80. blood is trying to come back. When the blood is trying to come back, first let me draw and then I'll try to explain to you. I don't know whether it will be simple to explain. Remember that the blood which is trying to come back, that blood is, see, this side I'm drawing the cusp when the blood was going up, okay, into the aorta. And that side cusp I'll draw and the blood is trying to come back. When we say blood, that blood is from year till year. Blood is in the whole of the aorta. Blood is not a partly in the aorta. Blood is filled up the whole aorta. So when the blood is trying to come back, it's not an arrow. It is coming back from this till this much. The blood is trying to come back. When the blood tries to come back, the blood fills up in this, and this cusp is, it's filling up here. Okay. Technically, it is filling up here also in this cusp and in the third cusp also. All three cusps are getting filled up. And as they keep getting filled up, I'm changing color just to show you. This cusp, as it is getting filled up with blood, is coming like this. Now, blood has come all over here. Similarly, this cusp has also got filled up with blood. Similarly, that other cusp which was there is also got filled up with blood. All three cusps are now coming together and they close. But there is no fight here between somebody trying to pull it and somebody trying to push it. Therefore, the second heart sound is formed by the closure of the pulmonary and the aortic valves. And it is smaller, lesser in intensity than the first heart sound. Simple way to remember, first heart sound has got 4 alphabets in it. Second heart sound has got 3 alphabets in it. So it is lower in intensity. Very easy way to remember. So now see, this is the wall of the aorta and my fingers are the cusp. Thumb is the wall of the aorta and the fingers are the cusp. You can't see the other thumb, but you know I have another thumb, so don't worry. Now when we'll see only in one, so you can understand, when the blood is trying to rush back, it enters even in between these two. And this cusp is coming like that. Similarly, the other cusp comes like this. And when these three cusps come together like this, the valve is closed. And there is no fight, so it is a small sound. Or you can see, I can make you understand like this. This is my shirt. Now this is the valve. That shirt is the wall of the aorta and the pocket is the valve. Now when the blood is going from the ventricle to the aorta, this has become flat. It is against my shirt. But when the blood tries to come back, it is filling up like this. So it has filled up like this. This is another valve which has filled up like this. And that's the third one which has filled up like that. All three semilunar valves are filled up. And when the semilunar valves are filled up, naturally the opening will be closed. Theoretically, if you ask me, you will say, sir, little blood will go in between before they all close. Yes, little blood will go. That little blood is not the rule. It is the exception. That little blood we are not bothered about. All the blood which has gone from the ventricle, some of very minute quantity will come back. Let it come back. It's all right. That doesn't matter. So that is how the semilunar valves are closed. Important thing is, when the semilunar valves are against the wall of the aorta, see that the openings of the coronary arteries are closed. So even if the heart says, give me blood, blood cannot go into it because the cusp is closing. Right? Somewhere here inside my pocket, there is the opening of the coronary blood vessel. But when the blood is going from this, it is going to close this automatically. The opening of the coronary vessel is closed. Coronary artery is closed by the cusp. And because it is closed by the cusp, it cannot give it, blood cannot go into the coronary artery even if it wants to go. When it is coming back, this is filling up with blood. So it has filled up with blood like this. Okay, when the blood fills up, the cusp will look like this. Cusp will look like this. The cusp which was flat like this becomes like this. It will fill up with blood, right? This thing which is filled up with blood, it looks like it is filled up with blood because this is trying to come back at 120 millimeters of pressure. So this will make it like this. It will not remain flat. Cusp cannot remain flat like this. It will go down under pressure. And therefore, this is wrongly called aortic sinus. There is nothing like aortic sinus. It is just that the blood is trying to come back. And now the blood is collecting in the aortic sinus. And in this aortic sinus, now here there is an opening of the coronary artery. And therefore, blood can go into the coronary artery during diastole of the heart, not during systole of the heart. Okay. With this much understanding, let's go and see how a coronary sinus looks. Come on. See that? See how that bulging has occurred. Come on. See this? One cusp, second cusp, and third cusp. That bulge has occurred like this. Okay. And that bulge is because of the pressure of the blood trying to go back into the ventricle. It is trying to push as much as it can push, and therefore it becomes like this. And that is called aortic sinus. And therefore blood is collected now in the aorta, the first part of the aorta, that is called ascending aorta, and that is where the coronary artery opening is. And because the coronary artery opening is there, the blood will flow into the coronary artery, and it is at this time that the heart is resting, the ventricles are not contracting, and therefore it can go inside. Can you see this? So this is the opening. And that is where it is going into the coronary arteries. Okay. And of course, you saw that opening there in the previous diagram that I had shown you. And therefore, that is how the blood goes into, or here also you can see nicely. This is the ascending part of the aorta, this much. This is the coronary sinus, or this is the coronary sinus which has occurred. Sorry. Talking of coronary, I'm telling you the wrong word. This is called aortic sinus, not coronary sinus. This bulge is called the aortic sinus, not the coronary sinus. Coronary sinus is something different. This is coronary sinus, this big vein. We'll come to it, but then this is called aortic sinus and not coronary sinus. This is called aortic sinus. Okay, the three of them bulging, and from that is where the coronary arteries are going to start. So, two things we learned about coronary circulation. One, it occurs during diastole of the heart, and why it occurs we saw. That is one. And let's see the other thing. So, this is the atrium, this is the ventricle, this is the atrioventricular groove. This is the atrioventricular groove where it is seen anteriorly. If we turn this posteriorly, these are the two atria, these are the two ventricles, because this is apex, this is left ventricle, this is right ventricle, because this is inferior vena cava, this is right atrium, so right ventricle, and therefore this becomes the atrioventricular groove or the coronary sulcus. So coronary sulcus will start from here, anteriorly like this, go behind, right? From there we are going to pick it up. So it is going to be something like this. Posteriorly back to this. This is the coronary sulcus. Behind, the line that I've drawn is behind. That means this black line which I'm representing, this black line is here, posteriorly, not anteriorly. Okay? The black line which is represented is behind, not in front. This is showing you that it will be behind like this. So that is completing a thing like this. This is the crown which fits on the head, and that's why it's known as coronary circulation. Simple words we will do. We'll do first very simple words so that you understand. This is atrioventricular groove or right atrioventricular groove. Right atrioventricular groove. Correct? This is behind. So this is left atrioventricular groove. Right? This is again atrioventricular groove seen from behind. So this whole thing is an atrioventricular groove seen from behind. This is atrioventricular groove seen from front. So the coronary arteries lie inside these. Their branches lie in other grooves also. So this is anterior interventricular groove. Anterior interventricular groove. This is posterior interventricular groove. Again, please note this nicely. This is apex. If this is apex, this much has to be left ventricle because that is left side. Therefore, this which I have not done, or this is right ventricle. And therefore, this is interventricular septum. Interventricular septum is inside. Interventricular septum is on the surface shown by a depression, and that is known as posterior interventricular groove. This is right ventricle. This is left ventricle because this is the apex. This is left ventricle. This is where the interventricular septum will be inside, and this is on the surface shown by anterior interventricular groove. So this is anterior interventricular groove, that is posterior interventricular groove. Without thinking anything, I'm just cutting short and telling you, if an artery will lie in the, we'll change the names again, but this is just to make you understand. If an artery lie in the anterior interventricular groove, it is called anterior interventricular artery. Very simple way, interventricular artery. If it is lying in the posterior, it is known as posterior interventricular artery, though we'll change the names afterwards. But this is what I'm trying to explain to you. If the artery, the whole of the right, in the right side of the sulcus, the artery which is lying has to be the right coronary artery. And the left coronary artery is going around the pulmonary trunk. You can see pulmonary trunk has been cut here and it comes out here, and we'll talk about it, blah, blah. So let's start. First, let's pick up the right coronary artery, which can be seen easily, whose branches are easy to remember, and we'll start with it. Right coronary, now I'm not doing course, I'm doing branches directly. And then we'll do course and branches, and course you don't have to remember. This is the right coronary artery. Right coronary artery, where it is going to turn posteriorly. Where it is going to turn posteriorly. Before it turns, it gives out a branch known as at the border. And because it is giving out a branch at the border, its name is marginal artery. At the margin, it is giving out a branch. It gives out a branch called marginal artery, turns posteriorly. Let's pick it up here. It has turned posteriorly, and here it is coming like this, and it is going to meet the left coronary artery somewhere here. But before it meets that, it gives out a big branch, which is going to go in the posterior interventricular groove, this branch, right? And for the time being, let's call this posterior interventricular artery. We are going to call it for time being, and many cardiologists refer by this name also. Some cardiologists refer by another name. So we'll change the names as we require. So this is posterior interventricular artery. Which one? This one. This branch. And then there's going to be a lot of complication about this. So for the time being, you just remember it has gone posteriorly. It has given out a branch called posterior interventricular artery, and it has anastomosed with the left coronary artery. Okay, let's see this. In 2-3 diagrams, we'll see this. Then we'll talk about it. Right coronary artery, here, it is giving out this big marginal here. Then it has gone behind. So you can see this because this heart is made of glass. And it has given out a big branch, which is called posterior interventricular artery. This blue one, posterior interventricular artery. This will do after 1 second. This is to again show you that the openings are situated. This slide should have gone 2 slides ahead. This is where these are, and this is the right, this is the right coronary artery coming out. That is the left coronary artery coming out. And we'll come back to this diagram when we start left. I'm purposely leaving it. This is what has happened is dye has been injected into the artery. After dye is injected, that dye solidifies. This dye is something like candle, wax dye. This is not a coronary angiography dye. This is like wax. And once it solidifies inside, we take out the heart and you can see all the arteries nicely. So this is the right coronary artery, right? This is given out the marginal, and this has gone behind, and this is the posterior interventricular artery. So we have only done this much, marginal and posterior interventricular artery. And one more diagram, and then we'll stop and go back. So this is right coronary artery giving out marginal artery. This is going behind and it is giving out this posterior intercostal artery. Okay, with this much, let's go back and talk. Now, this is the main artery and its two main branches that I spoke about. What I didn't speak about, which is not going to be there in the angiography report, is this artery is going to give multiple branches to right ventricle. It is giving multiple. See, it is not going just to give out big branch and go posteriorly. It is giving out multiple branches to the right ventricle. Can you see that? Right? It is also giving multiple branches to the right atrium. But these are understood branches, that it is going to the right atrium and to the right ventricle. We are not interested in blood supply. We are not learning anatomy of the heart. What we are learning is there a blockage in this artery? Coronary angiography is what we are learning today. So we are looking for the course in which there will be blockages. Okay, so the big artery is the right coronary, marginal, and the posterior interventricular artery. We are looking at only these three words. We are not talking about the blood supply of the atrium and blood supply of the ventricle, but just so that you don't forget, we'll see the slide, one slide later on. So here you can see multiple branches. This is what I'm trying to show you, right? So see the multiple branches which are supplying the atrium and the ventricle. This is showing all ventricular branches. This diagram is not showing any atrial branches, but there are atrial branches, there are ventricular branches. And in general, if you want to know the blood supply, we'll see that later on. This is again to show you these are atrial branches and ventricular branches. I won't show you this in the left again. So this is as much as right is concerned. Left coronary artery, once it comes out, it divides into two big arteries. So this one and this one. It divides into two big arteries. So when it comes out, it divides into two big arteries, this one and this one. So let us see this diagram. This is of course seen from above, that is aorta. This is the right coronary artery going down like this. It is giving out marginal and it is going behind and it is giving this posterior interventricular artery. Forget the names, right? Come here. This is the left coronary artery. Left coronary artery, as soon as it comes, it divides into two big arteries. One is known as LAD. LAD is left anterior descending, and this is left circumflex. CX is circumflex. We stop here and we go back and see. So this is the one which is coming down in the anterior interventricular groove, which should be called anterior interventricular artery, which is also called by many authors and many books. This is called the anterior interventricular artery. Most of the clinicians refer to this as LAD, left anterior descending, because it is coming down. Left anterior descending. It is coming down in the front, in the anterior interventricular groove. So LAD, LAD, LAD. This other artery, which now I'll pick up in red color, is turning around the heart and is going behind. So it's like it is completing the circumference of a circle. And because it is completing the circumference of the circle, it is called circumflex artery. And this red one, left circumflex artery, we are going to stop because it is 11 o'clock. And we'll pick up the circumflex and the LAD tomorrow, on Saturday. Okay, so we have done little of right coronary, nothing of left coronary, and we'll stop here. If you have questions, ask me. I'm allowing you to mute yourself and you can ask me questions. You can mute yourself and ask me questions. If you don't want to ask questions, say that we don't want to ask questions. You go like that. Somebody has put here in the chat that I'm not able to see the screen. If you're not able to see, most probably your network is gone. If all of you can't see, then immediately shout. Hemodynamic is something functional, and this will be explained to you more in physiology and when we do diseases. It is not a normal, it is not normal anatomy, it is abnormal, and that is not even physiology. So later on, disease it is. Do you want to ask any questions? Do you want to ask any questions? Say no, na, shout no.
No, no.
No,
No,
all
sir.
of you are
No, sir.
good. Good. So we stop here. You will have a small break and then the next lecture will continue.
Okay, sir.